Good afternoon, everyone. At the outset, I'd like to mention this couple here, Dr. Mohan Rajan and Sujata Mohan. They're one of the top couples in ophthalmology and obviously in Chennai. And they've got a huge practice with about more than 6 centers. And it's such an honor for me to be invited by Mohan and his wife, who both are excellent surgeons, for this course. Mohan's film on Panchorexis won in the film festival in the Asia Pacific region. Saying that, ladies and gentlemen, I'll talk to you on a problem which we all face. And let's see this case just now. Now this patient basically, as I'll show it to you just now, was like this. And I was having difficulty in rotating. When I have difficulty in rotating, there are only 2 things present. One, start praying, or ring up Toronto and ask Ike Emmett to fly down and help. So I obviously couldn't do the second, so I did the first. Because obviously, the moment I went inside, you can see I should have realized when I had the difficulty in rotation that nucleus is gone. Now the nucleus is obviously gone, so the next step is suture the clear corneal incision. Now, I'm trying to do a posterior assisted levitation as I can see the nucleus there. But look, I can't find it. When you don't see something, don't search for it. So I've closed up and forgotten the PAL technique. I'm going in and doing a vitrectomy, clearing up everything there. And you can see that nucleus lying on the retina. I'm doing my vitrectomy. Once I've done it, I'm taking off this trocar. I will enlarge the incision a little bit. You can see, this is to keep my phaco needle inside. And this technique is called SPAL, Sleeveless Phaco Tip Assisted Levitation, published in the BGO also. Now there is only fluid in the eye, so I go in with aspiration. Watch, I'm just aspirating. Once I have brought it up anteriorly, next step is I will just embed a bit. So you can see there, I've just embedded that. Once I have done that, I will now bring that nucleus anteriorly. And you can see I'm doing that just now. Once I have brought the nucleus anteriorly, the next step for me is, how do I remove this nucleus? I can extend the incision, but I will lose a lot of things in that. So instead of that, what I'm going to do is, I'm going to implant an intraocular lens inside. So before that, I'm going to first suture up that scleral tunnel incision. I'm taking my 3-piece IOL, and you can see here, I'm now going to inject this IOL inside the eye, but above the iris. So I'm injecting it above the iris, behind the nucleus. Now what is the game plan? The IOL is going to act like a scaffold, a temporary platform, and you can see one haptic has gone above the iris, the second haptic is now gone above the iris there. Now I inject some viscoelastic to protect the endothelium. I have got my air pump on, so I go in with phaco, and you can see I can emulsify this nucleus. It's a hard cataract very easily without the fear of the nucleus falling down. So this technique of IOL scaffold helps us to prevent any other complication if you have a PC rupture and nucleus fragments still inside the eye. So you can see there, I'm removing this one by one. Once these fragments have come off, now the next question is, where do I place my IOL? I do not know how much of rhexis margin I have. So what I'm going to do is, before that some cortex might be there behind, so I just go through the pars plana. Cortex removal is very easy because it'll come out with a vitrectomy probe. The problem is always in the cataract or the dense nucleus. So final portions of that cortex coming out, you can see the disc, the macula, everything looks nice. Small piece of cortex here. So I just stay above that, and on aspiration, you can see now I am aspirated that off. So far so good. Now what we do? We do not know where my rhexis margin is. So at this stage, dilate the pupil. So I'm dilating the pupil and I'm using iris hooks so that I can assess how much of rhexis I have. If I did not have rhexis, I would have simply done a glued IOL. I have rhexis, so all I'm going to do is dial this lens into the sulcus. Once you have done that, the next step for me is to close up this whole area, and this is what I'm doing just now. And you can see how the case looks when it is completed. This is the patient, same patient, post-operative day 1, little bit of SK, but 2 weeks post-op, the patient improved to 6/9 vision. Saying that, the next case I thought I'll show you is a case which is titled as never-ending case. So let's see what this is about. Now this particular case, which you will see just now, I titled it as a never-ending case. So if you see in this particular case, there are multiple problems. This is the patient. He had a drop nucleus. There was retinal vein occlusion. The patient had glaucoma. But the most important was, he was a one-eyed patient. That was the only seeing eye. So I went inside, made my scleral flaps. I made another flap for trabeclectomy. Now, I'm using my iris hooks because I want to dilate and see what's going on. I'm using a chandelier light. You can see a chandelier light there, which gives me illumination, and you can see the retinal vein occlusion there. I've done a vitrectomy. Once I've done a vitrectomy, I needed to extend the incision a little bit for my phaco probe to go inside without the sleeve. I've caught this nucleus there. Once it is caught, I will bring it up anteriorly. Now the problem here I face in IOL scaffold is, this iris is very floppy. And I'm scared what will happen if I put my IOL above the iris, because it's so flappy, I might drop the IOL. So what I decided is, don't go very posterior in your sclerotomy which you're making for the glued IOL. I decided to do a glued IOL scaffold. In other words, first I'm going to do a glued IOL, and then I will use the glued IOL which will work like a scaffold. So here you can see now, I'm going to do the glued IOL now, and once I've got my first haptic in, I'm now going to externalize the second haptic. So you can see there, the second haptic there, and externalize the second haptic by the handshake technique. It's a bit tricky because you already have a nucleus there, but once I have got both done there, I can now tuck it into the 26 gauge needle Chariot's pockets. Once both haptics are tucked, I know my IOL is stable. So next step for me is, let me go in and remove this nucleus. So now I go in with my phaco probe, and I told you this technique is the glued IOL scaffold, because the glued IOL now works like a scaffold. But now watch carefully here. Notice in this excitement, my haptic was above the iris. And when I'm repositing the iris, I realize it. So now what do? I have to re-internalize the haptic because it's gone through the iris. Once I have re-internalized the haptic, I have to go back again and re-externalize it back again. One assistant is holding the other haptic so that it doesn't drop down. So I go back to my handshake techniques, you can see, using two glued IOL forceps, catching the tip, but now you see my haptic is not through the iris. I again create a fresh Gabor-Chariot's pocket, tuck the haptic inside there. Now remember, the patient had glaucoma, and remember this was a one-eyed patient, he's the only seeing eye. So I finish my glaucoma at this stage, this area I will suture. You can't apply glue in these areas. So I've done the iridotomy there, apply the suture the trabeclectomy flap, and also suture the conjunctival area there. Case not over. I still have pupil. So what I want to do is, I may want to make my pupil better because it's messed up so badly. So what I'm going to do is, I'm going to do some pupiloplasty. And if someone wants to learn pupiloplasty, believe me, the best is the guy sitting on the head table here, Ike. The way he does iris repair is something phenomenal. So here you can see now, I'm doing my pupiloplasty, sealed everything down there. But case still not over. So what do I have? I've got a glue dial in place. I'll put in air. Now I apply the glue, seal everything down. Once I have sealed everything down, the next step is, remember, he has a retinal vein occlusion also. So I'm going to go inside with an intravitreal Lucentis, and I'm injecting intravitreal Lucentis in this patient. And this is how the case looks at the end. But after all this never-ending case, how did the patient do? Remember, I told you he's a one-eyed or a zero-eyed man. Post-operative 2 weeks, vision was 660, and subsequently, this is how the patient looks, and 2 months post-op, the vision improved to 624, and the patient was extremely happy. Saying that, the last clipping which I thought I will just show you here of another patient with a drop, but again something different which I thought I will show you here is this particular case, you can see, had bullous keratopathy. So what I decided in this case was, let me do it with this new technique which we started called PDEC, or pre-Descemet's endothelial keratoplasty, in which I'm creating a type 1 bubble here. Once I've got my type 1 bubble, I will then dissect this graft. Remember, a DMEC cannot be done in donors under 50, whereas in PDEC I can even do it with a 1-year donor or younger, and I get a 25 micron graft. So I'm going to do this dissection here. Once I have taken my graft out, that's a type 1 bubble, and I have to say, I've done this in collaboration with Harminder Dua. I come back to the patient. So this was the patient here. I take out the epithelium, and what do I see? An anterior chamber IOL. So I go in for my glued IOL, and you can see now, clearing it up. Once I have done that, I want to explant the IOL. So I make my scleral tunnel incision, but watch. Something is moving in the vitreous. Look at that. That is a drop nucleus. The previous surgeon had dropped the nucleus, left it behind, put an ACIOL, and in the bargain, the cornea is messed up. So what I decided to do is, I'll take a scissor and cut the haptics. So I'm cutting the haptics because they are entangled to the iris there. Once I have got it, the game plan is simple. I will just explant this IOL. Now you see, I'm going to catch that intraocular lens and explant it, and to my dismay, gone. The previous surgeon just dropped a nucleus. I dropped the IOL also. And ladies and gentlemen, have you heard of anybody dropping an anterior chamber IOL? I am the worst surgeon. And if you have not seen Rock and Roll, please see now. Okay, nucleus, IOL. Nucleus, IOL. Dancing in the vitreous cavity. At this stage, the only thing to do is start praying. So I'm praying now, and suddenly to my luck, the nucleus comes anteriorly. So what I do now at this stage is, I'm not leaving it for dear life. So I find something shining in the anterior chamber, I pull it out, and what do I see? Haptic. Haptic of the broken or the cut anterior chamber IOL. Now I go in, remove that nucleus, and to hell with the cornea. Don't worry, the cornea is already gone. But remember, IOL is still there. Okay? So I'm going to do a vitrectomy, and a trick taught to me by Dr. Ashwin is this extrusion cannula, using it. So watch this. I'm using the extrusion cannula, sucking it, lifting it up. Once it comes up, I will now shift to a forceps, grab the haptic, Once the haptic is caught, or the broken haptic as I can call it, again I'm not leaving it for dear life. I'm using in my left hand a rod to support that IOL, catch that IOL, bring it out. Once that's out, I will then shift to a glued IOL. So you can see I'm catching the haptic, externalizing the first, then shifting to that handshake technique, grabbing the second. Remember one thing, please don't go very posterior in your sclerotomy. I see surgeons doing 2 millimeters, 2.5 millimeters. The more posterior you go, the less haptic you have externalized. So come anteriorly, nothing will happen. See the amount of haptic externalized I have. If you do the surgery well, there's no way the glued IOL will dislocate. But case not over, I have to do pupiloplasty. Why? Because now I need a whole sheet of IOL working like a trampoline when I fix my PDEC graft, because it works like a trampoline and the air is pushed up. So you can see there now, I'm now going to take off the endothelium. Look, portion of the endothelium was damaged by the first surgeon.
Amar,
Remaining was by me.
yeah, can you just wind up? Yeah,
And now,
no problem. Finish it fast, no problem.
and now we'll just implant the PDEC graft, and you can see here how the case looks when it is completed. And that's how the case is at the end of the case. Thank you very much, Mohan.
Thank you, Amar.